John Bennett. We're broadcasting live from Miami. We have here another conference for the Conference of Emerging Trends of Neurotrauma, directed by Iype Cherian. And we have the pleasure today of having Iype Cherian. He's going to talk about cisterostomy, breaking the web. Good day, Iype.
Good morning, John. Today we will talk about what is cisterostomy, what is the physiology behind it. We will discuss a few scans, we will see our results, and we will dwell a little bit on the operative surgical anatomy part of it, and we will see what's the acceptance we have. So the present surgery, decompressive hemicraniectomy, it was first described by Emil Kocher in 1901. So what Kocher said was that if there's no CSF pressure but brain pressure excess, then pressure relief must be achieved by opening the skull. Now, to look at it, we must assume that the CSF pressure was measured by doing an LP. Although Theodore Kocher was a pioneer of ventricular puncture, we have clear evidence to believe that CSF pressure was not calculated at that time by ventricular puncture. So obviously, somebody did an LP, and then they didn't find any CSF pressure because obviously the brain was herniating. And when they did not find that, they also had features the patient having very high ICP. So here's the scenario: patient having very high ICP and no CSF pressure, which is by LP. So that is when Kocher said, if there's no CSF pressure but brain pressure excess, then pressure relief must be achieved by opening the skull. Now, with all our advanced imaging, surgical evidence, we know that this is a false statement. It was right at that point of time, but not anymore. So, in fact, decompressive hemicraniectomy stands on a flawed ground, on a wrong grounds, but it has survived for over 110 years. Now, that's something because I would say people are afraid of change. Everybody is afraid of change, and people still believe that decompressive hemicraniectomy helps. Yeah, it does help a bit, but in this era when microsurgery and a lot of other advancements has come into neurosurgery, doing an old surgery like decompressive hemicraniectomy is not the right thing. Now, building a case. What is the cause for edema in the post-traumatic brain? Where did the CSF, the 120 ml of CSF in the cisterns, where did that disappear? Now, you know that there's 120 ml of CSF in the cisterns. And if our surgeons knew enough physics, they would know that no fluid is compressible. You cannot compress 120 ml. Yet, after 2 to 3 hours, you don't find any cisterns. So most of the time when I ask people, where did the CSF disappear? They said, oh, it went into the spinal canal. Impossible again, because the spinal canal cannot accommodate it. Already accommodates only 40 to 60 ml. It cannot accommodate another 60 ml more, because if it does that, the pressure in this, in the spinal canal is going to go. The pressure is going to go very high. So it cannot happen like that. So where is the CSF going in? Now the third point, in fracture skull base with CSF leak, the chances of brain edema is perhaps lower than in a similar population of head injuries. This has been told to me by many people, including skull base surgeons, trauma surgeons. They have said that although fracture skull with CSF leak presents the chances of meningitis, the patients do well. You know why? It's already a cisterostomy there, because the fracture skull, the fracture skull base is already, with the CSF leak, is already has done a cisterostomy there. So probably why. I'm just putting forward a hypothesis. Now, a few observations. I'm not jumping into any conclusions, just a few observations. Trauma and acute subarachnoid hemorrhage, especially the WFNS 4 and 5, they look similar. Now, I know guys are going to jump at me and say, oh, no, this is different anatomy, this is different physiology. Yes, I'm not saying anything. I'm just saying they look similar. If anybody has operated severe head injuries and acute subarachnoid hemorrhage, WFNS and 4 and 5, the brain looks very similar, red and angry. Now, opening cisterns for subarachnoid hemorrhage relaxes the brain. That's something which is known and practiced for over 50 years. The new studies on CSF pathways suggest that CSF travels into the brain from the cisterns and may be the cause for acute edema. So if somebody refers to the G lymphatic pathway by Iype and Nedegard, and in fact, that paper was published in 2012. I have presentations which date from 2009 onwards, stating that there is a pathway probably which follows the Virchow-Robin spaces, and the CSF goes in from the cisterns to Virchow-Robin spaces, because I had to explain how cisterostomy was working, and the only way I could explain was this. And when I saw this published paper, Iype and Nedegard's paper, I was overjoyed actually, and that was, I never had any facilities to prove what I was saying, but these guys did it. Now, lactate storm in acute trauma is damaging, and lactate clearance from the brain via CSF is important. So this is another point that I want to highlight. So with these few observations, I'm building up my case and I'm making it further stronger again. And well, this is one no microneurosurgeon can deny. Microneurosurgery is always given better results compared to gross surgery when done by specialists. Now, there was a time when CP angle tumors were taken out with the finger. I mean, that's no more the case. If anybody takes out a CP angle tumor in this day with a finger, you know where that finger is going to be. So it's not done anymore. But yet, for the highest load for neurosurgery, which is trauma, we still practice, gross surgery. We never put the microscope in. We don't use any advanced techniques. There may be a few reasons for this. One is trauma surgery is always an emergent surgery. You know, once you become a senior, it's not that you want to go for an emergent surgery. No professors would come in the morning at 2 o'clock and then put a microscope and start and sit and drill a posterior clinoid. They wouldn't want to do that. Nobody senior enough would be mad enough to do that. But yet, one has to understand that trauma patients deserve the same treatment or even better than an aneurysm patient or any other patient. So residents have taken over trauma, not only in the developing world, in all over the world. The residents have taken over trauma, and all these leading places where professors, I mean, there are big names. You go to those places and people don't understand that it's the residents who do most of this trauma. Now, let's get to the CSF circulation. Now, the old belief for CSF circulation was lateral ventricle to third ventricle to fourth ventricle to cisterns, and from cisterns via arachnoid granulations and then to the superior sagittal sinus. Now, this is a new theory, which means from the cisterns there through the Virchow-Robin spaces, we have a circulation which is going into the brain, cooling and cleaning the brain, and coming back. And from the brain through the capillaries, veins, it can either go to the sinus or it can go through the G lymphatic system as a lymphatic drainage. It's not very clear, but this is the new system, and this is the system which we are making use of in cystostomy. Now let's say the brain and the cistern are two communicating spaces. That's what we said, and it communicates through the Verschurovin spaces. So let's say when there is subarachnoid hemorrhage, you all know that the vessels are in the arachnoid, subarachnoid compartment or the systems. So when the vessel starts bleeding, they start bleeding at, the capillaries start bleeding at least 50 millimeter Hg, 50 millimeter mercury. So when they start bleeding, the pressure in the systems is going to go up. So the brain pressure may go up because of some contusion or some mass occupying lesion, but usually it doesn't go up to 50. So you have a gradient, and that's what happens. The systems discharge the CSF through the Verschurovin spaces into the brain. Now I am aware of the aquaporin 4 transport, but when there is a gradient which is very high, I don't know whether aquaporin 4 would work or would still be applicable. Now, when the systems discharge the CSF into the brain, this is what happens to the brain. It starts swelling up. Now, in a scenario like this, if you're going to open open 13 centimeter flap and on the top and allow the brain to swell, this is what happens. That's the aftermath of decompressive hemicraniectomy. It decreases the ICP, but there is axonal stretch, severe damage to the stretched brain. And obviously, we all know this is what happens after DHC. So what's the answer? The answer is, so that's a swollen brain, that's a cistern, and that's what happens in trauma, and that's me. I come in and open the cisterns, there's a backshift of CSF in the cistern, and the brain pressure goes down. So I would like to reiterate this again, because this is the most important thing. This is the basis of cystostomy. So cistern subarachnoid hemorrhage, cistern pressure increases, the cisterns discharge into the brain, producing acute brain edema. This is called a CSF Shift Edema. We have published this very recently. And you drain the cisterns, voila. And that's what happens. So why does the ventricular drainage not work? This is a question which I have been asked many, many times over. Right now, most of the places do ventricular drainage. And, the ventricles have only 20 ml of CSF. And we all know they are compressed. With the navigation techniques these days we have, you can tap the ventricle, but you're not going to drain more than 2 ml or 3 ml a minute. I'm sure of that, because we have done this in a large referral center, and we in India as well as in Nepal, and we know what are the results with ventricular tap. And I don't think anybody can claim that with ventricular tap they can decrease the ICP. They cannot. It's a conservative form of management. And more importantly, the ventricles don't communicate with the parenchyma. This is what I'm going to show. Cisterns have 120 ml of CSF, and they communicate with the parenchyma. That's the reason why, in the first place, that CSF went into the parenchyma. Ventricular CSF rarely goes to the parenchyma. In severe hydrocephalus, there can be hydrostatic edema. That's the only time there's some amount of CSF going into the parenchyma. So this Iype and Nedegard group, they injected, let's say they injected an agent into the ventricle and into the cistern, And after the injection, see the ventricular injection, there's no communication. That agent is not found in the parenchyma. While in cisternal injection, you see that, how bright they seem, and those places where that green is seen, probably the Washer-Robin spaces. So we started this study in August 2007. It was a stepwise evolution from decompressive hemicraniectomy to cestonostomy. And this was because an accidental discovery that opening cisterns was beneficial for decreasing the pressure. So we started doing decompressive hemicraniectomies with cisternal opening. Initially, we used to open only the opticocarotid and the lateral carotid cisterns because it was very difficult. We did not use any skull base techniques. We just did a large decompressive flap, bit up to the base, and then went under the frontal lobe, retracted and opened the interoptic and opticocarotid, and kept the bone flap out, and then came back. That's how we started, and then we proceeded on to when the brain was lax, we started putting the bone flap in, but still with a large temporal craniotomy. And then we started putting the bone flap back after being able to open the membrane of Lilliquist, which is a very, very important step. We started we started keeping the bone flap back, and then that is cestonostomy. So it was a stepwise evolution. It was not as if we suddenly shifted from decompressive hemicraniectomy to cestonostomy. And even today, if there is a need for decompressive, I would rather do it, although it's the indication is very rare. And I always tell people who say that this is a new surgery, I'm not doing anything new. Actually, I'm doing a decompressive flap. I'm opening the cisterns, and after the brain is, if the brain is lax, there's nothing wrong in putting the bone flap as a floating flap. So I never fix my bone flaps. So there's nothing new in that. So you shouldn't be saying that cestonostomy is something new. And by the way, we did not do any randomized controlled trial. I hope you know about the parachute paradox. Now, selection criteria. Now, we did not have a selection criteria in the beginning for people who classified for decompressive hemicraniectomy. We used this surgery. We just opened the cisterns along with that. But later on, as Dr. Garnet Sutherland came to Nepal, he helped us with making this systematic. He is a big believer in this, and he made it to be systematic. So we developed this Nepal Calgary CT clinical grading. Again, ICP monitoring was not used in decision making. We saw the CT scans. We looked at the clinical grading if there was any deterioration, and then we went ahead and did proactive surgery. We did not wait for the patient to be cooked, and then one management failed, then the other management failed, and then the third failed, and then we cooled the patient, and then we mummified the patient, and then we didn't start off the surgery. There are even papers saying that even decompressive hemicraniectomy, if it has to be done, it has to be done as early as possible. There's no point in failing 3 or 4 treatments before you start decompressive hemicraniectomy, even decompressive hemicraniectomy. Now, skull base and microsurgical principles were used as in the present day surgery. We did not use primitive torture techniques like decompressive. And relatives were informed of both the surgical options, and they were free to choose. So that's the beginning of that's part of the Nepal Calgary CT clinical radiological score. We scored for subarachnoid hemorrhage, mass lesion, herniation, ischemia, and that is the motor score of the GCS motor score. And we gave it grade 1, 2, 3, 4, depending on what is the motor score. The cumulative scores were added, and 5 to 12 was an indication for cestonostomy, 12 to 15. Cisterostomy was only indicated in young, healthy patients brought within 6 hours of trauma, sudden deterioration, and still having spontaneous respiration. Now, till Jan 2015, we had 792 severe head injuries classified for cisterostomy. And this is the comparison and outcome. Now, we did not have a lot of criteria. We know exactly when if somebody died, we knew. Ventilator days, we knew, because the patient, whenever they stay in the ICU on the ventilator, they pay, and so there was a record. And when the patient was in ICU, I mean, we again had a record, so we had that as well. And most of these patients used to stay around in the rehab for 6 weeks if they're severe head injuries, or they used to stay in and around Chitwan. And again, we have only 70% or less than that follow-up. So I wouldn't say that this is a very great statistics. But our mortality, when we calculated it with the help of a statistician, mortality for the DHC alone was 35%. I understand this is a little higher, but this is what our mortality was for a number of 284 patients. And then when we started decompression hemicraniectomy with cisterostomy, this 26.4 was the mortality. I would say it was still higher because we were not able to open. I believe that we were not able to open the membrane full request. And sometimes there were cases when we still had bad brain swelling, rebound brain swelling. So after we started the skull-based techniques and also started opening the membrane full request, the mortality came down to 13.8%. And I would say that it's still getting better. Ventilator days came down from 6.3 to 2.4. ICU stay came down from 9.4 to 4.4, and mean GIs went up from 2.8 to 3.9. Presenting some of the scans that we have. If you check my Facebook page, we usually update all the, I mean, recently we have started updating a few cisterostomy patients' scans with their permissions. We have a few of them, but these are few scans I would like to discuss. Now, on this scan, you can find that it's a pretty bad contusion on the left side. And what I would like you to see is you see the kind of edema here. You see the edema here. It's pretty bad. Huh? So, and plus, this sign, this cistern is widened. This means that the brainstem is getting pushed and there's impending herniation. It's not a great scene to operate this patient on. This patient, this is the post-op. We did not remove the bone flap. There's a small exterior. It doesn't matter actually. See, the edema is getting better, and this patient came walking 8 weeks later. This is a scan of another child who presented with a motor score of 5. When we got a call from the emergency saying that he's just gone into decorticate posturing. So we rushed him. With the same scan, we rushed him into the theater. And, you know, although this was the initial scan, motor score was 5. So you could see the cisterns were open here. So I was not very worried. But we took him to theater. The brain was pretty tight. So this was what, immediately after surgery, this was the picture. You could see the amount of damage. That's probably the reason why he started decorticating. So we put in a drain with a prepondine cistern. The drain looks pretty tight even now, but you can see the bone flap. It's a floating free flap. You know, you're not trying to prove anything. You're not trying to put the bone flap there and close and say that, oh, my cisterostomy is working and that's why the bone flap is not bulging out. We're not trying to prove that. It's a free bone flap. So the patient started improving, and this was at discharge, and at the end of 6 weeks, this is the guy.
What is your name?
Now there's another patient, GCS of 6/15, left pupil is dilated and fixed. You can see the midline shift here, and if this midline shifts anymore, the midline will go out of the skull. So I'm sure the standard practice here is a decompressive hemicraniectomy. You have subdural and you have a lot of swelling, so you do a decompressive hemicraniectomy. So that is our surgery, same patient. So that's our surgery, and this is the guy at the end of the 4th postoperative day getting out from the ICU. That is GCS of 7/15 with anisocoria. So this guy had probably a traumatic vein of labia infarct as well, along with a large subdural. So you can see the bone was in 2 pieces. So you can see the piece we took out here. You can see the piece we took out here, and this guy was GCS 15/15 with the right residual third nerve palsy at discharge. That's another one. You can see the edema here. I mean, I'm sure most of the trauma surgeons who would see that would understand this kind of edema. This patient was brought to us from a very far major city, and he was a very important patient. So here we found severe brain swelling, temporal herniation noted. There was contused third nerve. And once we did the cisterostomy, the brain was lax. So it's the same patient who was 14/15 at discharge, 15/15 now. He had mild right hemiparesis and residual third nerve paresis. This is another one with a GCS of 4T/15. This lady had both her pupils dilated before surgery. There was a small posterior fossa EDH which was evacuated, and you can see how bad the brain is here. I mean, it's severe edema and almost blackening of the brain. Here we did the cisterostomy. I would admit that it is so difficult to get into the systems that you could see that when you had to retract, you made a iatrogenic contusion right down there, but the systems were open and the brain is looking much better now. And this is the lady on the 7th postoperative. So that's another one with GCS 4/15, both pupils dilated and reacting sluggishly. You can see the brainstem shifted here. There's a posterior fossa extradural as well. Evacuated, and cisterostomy done, no decompressive hemicraniectomy there, and that's how the guy is looking. That's another one. See, this case, I'm not saying, I'm not trying to say that, oh yeah, you should do these kind of cases. But this case was brought to us with a GCS of 4/15. Both pupils were dilated, mild anisocoria, and was brought to the hospital within 3 hours of trauma, and the relatives were just not ready to say, just not ready to accept that we would not do surgery for this patient. And we went ahead and did the surgery, and this is how after surgery, it looked like this. I'm not saying it was a fantastic picture, but see the flap there. There's no bulging out of the flap, or there's no evidence of severe edema or herniation of the brain or anything. That's how this guy looked at. We tapped this subdural hygroma, but there was no pressure at all, so we left it at that. And he was E4, M5 at V2 at discharge. Right now, interestingly, we have another patient who came, both pupils dilated, very, very bad skin. He's walking around still with his both pupils still dilated. So, I mean, I'm sure you can see the scan. Let's see the scan of this patient on our Facebook account. Now, how do I do it? So for beginners, one should select cases. I mean, you should not go and start off with the most difficult of cases. I don't want you to damage your surgical confidence and then give the judgment that cystoscopy is not great. You have to do a DHC flap and craniotomy. Reposition the head with slight extension and tilt. Remove the sphenoid ridge till the superior orbital fissure. Open the dura in the DHC way. And in the window of opportunity, go lateral subfrontal and retract gently and use a suction to open the interoptic and optical carotid. Keep it right. And evolve to where you're confident of putting the bone flap back. Now, operative technique to deal with severe brain swelling. It's a modified Dolling's approach. Orbitomeningeal band is one of the most important things. Please refer to our video where we're talking about anterior clinoidectomy. You understand how important is orbitomeningeal band in this. Dural opening as close as to the supracella system. And why? So the orbitomeningeal band is something which you see on the lateralmost aspect of the superior orbital fissure. When you cut the orbitomeningeal band, you can dissect the frontal lobe upwards and the temporal lobe lateral, and in between you will find a anterior clinoid. Not only that, you will be able to preserve your true cavernous membrane when you are dissecting the temporal lobe off. So why do you want to dissect this frontal and temporal lobe off? That's because usually it looks like this, and once you take out the anterior clinoid and dissect the temporal lobe off, it's going to look like this. Not exactly on the lateral plane, it's going to look like that on the lateral and lateral as well as the AP plane. It's going to look at the temporal lobe is going to open up, and this gives you access to the space, the base. So after that, you go to the base, you open the dura, you go under the frontal lobe on just parallel to the skull base, you open the interoptic optical carotid and the lateral carotid system. Then once the brain is lax, you open the membrane of Lilliquist. This is very important to avoid rebound swelling. Then you see the basilar quad, which involves both P1s and the third nerve and both the superior cerebellar arteries and the basilar. And the prepontine system, exposure and washing out the blood. So you sometimes, very rarely, this is not an important point at all. Sometimes, if the membrane of Lilliquist cannot be opened, you can do posterior clinoid drilling. Now, a lot of people would laugh at it or say it's stupid. Posterior clinoid drilling in trauma? Yes, because if you're doing posterior clinoid drilling for once in a year, basilar tip, you jolly well do posterior clinoid drilling in something you see every day. So you better have those skills. And hemostasis should be with irrigation. I don't use the preferable. It's not good to anger on an already angry brain. So that's the anatomy that you will see. One of the observations that I see, there's a lot of venous bleeding in the beginning, and this happens with acute aneurysm surgeries also. The brain swelling, as the brain swelling starts coming down, the venous bleeding also starts coming down. Probably because the intra-brain pressure, intracerebral pressure is going down, and that's got something to do with the venous bleeding. Now, you're going to see a cisterostomy video. I'm sorry. Yeah, that's the transcavernous peeling. So you can see the V1 there, the V2 there. That's a superior orbital fissure, and that's a V2 there. So you see there's not so much bleeding as usual. That's because the true cavernous membrane has been preserved. That's after the dura is opened. So that's the optic nerve. That's a contralateral optic nerve. And I'm cutting the interoptic arachnoid. Then you can see the anterior communicating complex here. It's just like any vascular surgery. That is the membrane of Lilliquist. That's the carotid there. So these are the perforators. You have to be very, very careful. This is a very small. This is a 3 millimeter window. So that's an ACOM. And these are perforators, so you're cutting off those. You made some perforations in the membrane of Lilliquist, and you're cutting the membrane of Lilliquist there. This is an easy membrane of Lilliquist. I mean, That's optic nerve, that's a carotid, that's a PCOM. You cut the membrane of umbilicus there, you are directly seeing the basal artery. You see that? It's a pretty easy one. You see this one. I mean, when I was talking about posterior clinoidectomy, you see there's no way you can reach the membrane of umbilicus in this one. Okay, how much ever you mobilize your carotid, you cut your distal dural ring, you try to mobilize your carotid, you try cutting your falciform ligament, mobilize it. You're not going to be able to incise the membrane of umbilicus. Here you have to take out the PCP. So I'm doing this with the bone Cusa right now. So most of the time I use the drills, but if you use the bone Cusa, you see the anatomy. That's a basilar, that's a P1, that's another P1, that's a third nerve, and that is a sclerocircular artery. That's a carotid there, and that is optic nerve. And this is a suprabrow approach. This is my hand is forced here. It's not that I wanted to do this. Nobody would want to do crazy things like this, but my hand was forced here because we had a hematoma subfrontal hematoma. So we took it out, and then the brain was swelling, and so we had to do a cisterostomy. We opened the cisterns and we found the PCP in our way, and we thought, why not? And the brain was lax by that time, but we did not want to have rebound swelling. We waited for some time, the brain was swelling up again, so we decided that we will go for the PCP resection. Yeah, that's PCP resected PCP, and that's membrane of umbilicus being opened there. You can see both the P1s there. Yes, that's one P1, that's another P1, and that's an artery of Purcell. So that's one of the reasons why I showed this video. I always ask the residents as to what this artery is. So now when is cisterostomy not useful? Well, if there's a motor score of 1 and 2, some cases do improve. I mean, not to a complete 15 by 15, obviously, but they do improve to sometimes to 9 by 15. But if there are radiological features of ischemia with a motor score of 1 and 2, this is not a great idea to do this to do cisterostomy. Related contraindications would be a sinus bleed, severe bleeding disorders, and ischemic brain. Well, complications, we had to revert to DHC in 1.76%. Out of the 14 who reverted, 9 died, and 2 had bad GOS, 3 survived with moderate GOS. Vascular injury, 1 case of carotid injury, repaired primarily. Patient expired 6 days later. No infarct was seen on the post-op scan though. There was 1 case with PCOM tear, PCOM was clipped, no additional deficits was present. Pseudomeningocele, 19%, compared to 3% or 4% in decompressive hemocraniectomy. Hydrocephalus of 8%, that's 98 patients out of which 23 required shunt. So these are our chapters. This is the WFNS official textbooks, Essentials of Neurosurgery, and that is our chapter in 2012. That's a letter to the editor from Giovanni Grasso, my Italian friend, who came and saw cisterostomy in our unit. That is the World Neurosurgery article outlining the pathophysiology mechanisms and surgical technical notes from Antonio Bernardo from New York, Giovanni Grasso, and myself. This is cooling and cleaning the brain. This the role of CSF and paravascular system. This is the CSF Shift Edema. You can go onto the Google and type CSF Shift Edema or cooling and cleaning. You just probably need to put my name as well, and you're going to get these articles. They're free articles. This is a surgical technique for cisterostomy, and this is another article in the Asian CNS. This is the CNS surgical manual where we have the cisterostomy surgical technique. So in summary, the biggest killer in neurosurgical scenario is neurotrauma. Young neurosurgeons and residents need proper training. Trauma surgery deserves the same attention to details as skills as skull base and microvascular. Decompressive hemicraniectomy was the only workhorse of trauma surgery until now. It's time to hand over the baton. Thank you.
Thank you, Iype, for an overview of cisterostomy. Could I ask you a quick question?
Yes, please.
Yes. Are there any current studies going on cisterostomy?
Yeah, there are many, John. In fact, yesterday when Sridhar was speaking, he was telling about a study that he himself is doing. So they are planning for 30 to 40 cases of decompressive hemicraniectomy with cysterostomy. So there are over 30 centers who are doing this. Very few are doing pure cysterostomy, but what they're doing is the initial phase, what I started off with 8 years back. So they're doing a decompressive hemicraniectomy with cysterostomy, and the initial results suggest that the results are pretty good. So people are changing from pure decompressive to decompressive with cysterostomy, and I'm sure those people are going to very soon shift to cysterostomy. I took 5 years for that, but I'm sure it would be much earlier than what I did for most of these people.
Very good. Thank you, Iype, for an overview of cysterostomy, and we look forward to more videos. Thank you very much.